3, 2, 1. We are live now. We are live now.
Ritika?
I think everybody except the person who's going to introduce should keep their microphones on mute, please.
So please everyone mute your microphone. Welcome all. This is the first voice webinar with the Eastern Zone of India. And I would like to thank Voice India and Ritika. She has single-handedly arranged all this program. And we would like to have a voice physical program also during MidCon in July 2023 in Kolkata. So all of you are invited there. So without wasting the time, I will hand over to Ritika for further proceeding. Ritika?
Good afternoon, good evening, everyone. Thank you so much for joining us.
Ritika, your voice.
Maybe if you can wear headphones, that will be nice.
Ma'am, please start with the proceeding. We'll start with the opening note.
All right. So I think it's a very, very welcome move that West Bengal Association has initiated. And we are extremely proud of our young girls from the East and the Northeast who are joining us today, because these are pretty much underrepresented in voice as such to say. And we really wish to encourage participation of more and more women in ortho from that region, for which we will seek Rajeev Raman's help time and again. And I'd first take this opportunity to welcome Dr. Atul Srivastava, who is always been supportive. In fact, I think it is some sort of a fortuitous and providence kind of a thing today, that when Voice was born, Atul was in the secretary's chair. And today when Voice is taking a bigger leap, he's in the IOA presidentship. So I think this is a very, very big blessing for us that all new, good new beginnings are associated with Dr. Atul Srivastava's presence. So I'll first request him to give us a word of blessings, and then we will show the Voice movie.
Good evening all, and greetings from the Indian Orthopaedic Association. First of all, wish you all a very happy, safe, prosperous and a successful new year. And Rujuta ma'am said she's absolutely fine. We had this vision, and I'm so happy to see this vision growing day by day. And I would say it's like a synchronized symphony that the Voice today joins hands with the East Zone and produces this webinar. I hope this infection carries to other zones too. And I congratulate you all for this nice venture, and thank you for inviting me. Thank you.
So Ritika, are we ready with you?
Yes, we can have a welcome note by President WBA, Dr. Chandan Pathak. Chandan,
yes, please start now.
Dr. Chandan Pathak.
Good evening. And I am really proud today that West Bengal Orthopaedic Association is holding the first Voice meeting on behalf of East Zone. So our young girls are really with tails up to present their cases, and on this first Voice meeting of WBOA. So I think it will be an interesting evening today. And I thank on behalf of association for this first meeting on behalf of West Bengal Orthopaedic Association and East Zone tonight. Thank you all.
Thank you, Chandan. So, Rujuta ma'am, we have decided, welcome all, and thanks to Rujuta ma'am for this wonderful initiative, and special thanks to our convener, Dr. Ritwika Nandi, and all the participants from all over the India and the East Zone for participating in this wonderful webinar. So I have talked with my president, Dr. Chandan Pathak sir, and from next MidCon, we will have a voice session in every WBA con and MidCon. So every state conference and midterm conference, we will have a voice session. And a special thanks to Chandan Pathak sir for this permission. And we are going to start this from this year MidCon. And that will be the first physical meeting of Voice Eastern India. So all of you are invited. So Somadeep and our scientific committee will be in touch with you. So please join us.
Sure. Yeah. So Ritwika, I think what is great today is that a whole lot of young girls are coming forward. The idea has been to provide them a platform to come up with case presentations. And along with IOA, I think we will conduct workshops in the future also for something like a training of the trainers. But last year, very enthusiastically, we have prepared a movie about voice, because I think world over, every other country which has a strong women's presence in orthopedics, they have a movie like that. So I would like all of y'all to witness that. If I can just share my screen, please. Please do tell me if everything is visible nicely. I have to do share sound and optimize for video clip, correct?
It is visible, ma'am.
Yeah, but the sound is not coming now for some
No,
reason.
ma'am. It's coming, ma'am.
है सांसें बुलंद लड़ने चली हूँ आजादी की जंग बेखौफ आजाद है जीना मुझे बेखौफ आजाद है रहना मुझे बेखौफ आजाद है जीना मुझे बेखौफ आजाद है रहना मुझे गुजरे ऐसे हर रात रात हो ख्वाहिशों से बात बात आशाएं लेकर सूरज से आग आग आई जा अपना राग राग आशाएं कुछ ऐसा करके दिखा खुद खुश हो जाए खुदा आशाएं खिले दिल की उम्मीदें हंसे दिल की अब मुश्किल नहीं कुछ भी नहीं कुछ भी आशाएं खिले दिल की उम्मीदें हंसे दिल की अब मुश्किल नहीं कुछ भी नहीं कुछ भी चल पड़ी है हम सफर अजनबी तो है डगर लगता हमको मगर कुछ कर देंगे हम मगर ख्वाब में जो दिखा पर था छिपा बस जाएगा वो नगर रे 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 बादल पे पाँव है या झूठा गाँव है अब तो भाई चल पड़ी अपनी ये नाव है बादल पे पाँव है या झूठा गाँव है अब तो भाई चल पड़ी अपनी ये नाव है
So with this, I'll stop sharing the screen. It is what we call the song of hope that we have made this video all about, because I think the girls can certainly excel in every field in ortho. What we need to focus more on is providing them a platform, training them how to speak and face a crowd, and also train them in specialities which are a little tough, like arthroplasty, spine, arthroscopy, and make sure that we empower the youth in such a way that we are literally rubbing shoulders with the world. And as you saw, 7 women already from India have won the Marcella Uribe Zamodi Award in CCOT. And they've been pioneers like Dr. P.K. Mullah Firoz, Risha Madhuri, Purnima Patni, and Shobha Arora ma'am. And each of y'all has that potential. So I think I appreciate each and every person here today who is making the effort to come up. each and every person who is sparing the time to mentor them in some way. Every one of us, when we began our careers, we were also youngsters who didn't know and we were finding our feet. So girls, present confidently. Don't worry about your case presentation. This is the best way to learn, because teaching is always something which will take you deeper into the subject. And if you understand better, you will teach better in future. So without wasting much time further, let's invite the first speaker with their cases, and I will request everybody on the panel to ask them questions after each case is done. Neha and myself will be moderating, so we can put your questions in the chat box here. Over to you, Ritwika, to introduce every girl who's speaking today.
Right. Thank you, ma'am. The video was very nice to see again because I think a lot of people may have not seen it before. So, ma'am, our first speaker is Dr. Snejuti Bera. She's a junior resident. She's going to be presenting first. Snejuti, can you share your screen?
Ask her to unmute.
You need to
Yes.
unmute. Yes.
Am I audible now?
Yes, you are.
Good evening to everyone of the esteemed faculty members, Dr. Rujuta ma'am and IO President sir, and everyone, each and every one of our colleagues. I am Dr. Snejuti Bera, Junior Resident, Department of Orthopaedics at IPGME System Hospital, and today I am going to talk about an interesting case of en bloc excision of mass from metacarpal along with metacarpal reconstruction using fibular graft. So starting off with the patient particulars, a 15-year-old female presented with the chief complaint of swelling in the right hand for a few months with the history of trauma. There was a history of trauma by heavy object. And coming to the history of present illness, the patient was apparently normal 6 months ago when she sustained injury due to fall of a heavy object on her right hand, following which she complained of pain and swelling in the right fourth metacarpal. The pain was of insidious onset, dull aching, continuous, moderately severe in nature, progressive, aggravated on movements, relieved by analgesics. There was no radiation and it was not associated with any constitutional symptoms. The pain was associated with swelling of right hand, which was also progressive in nature and of firm consistency. There was no history of fever, weight loss, or any other constitutional symptoms. Coming to the history of past illness, there was no significant past surgical and medical history. The personal history was also within normal limits. On general survey, mild pallor was present at the time of presentation. There was no cyanosis, icterus, clubbing, or edema. So coming to the first X-ray image at the time of the presentation, we can see that there's an expansile osteolytic lesion at the fourth metacarpal of the right hand. This was the X-ray at the time of presentation. And subsequently, we did an MRI for the patient. This is the MRI image. So the MRI report showed a well-defined expansile T1 hypointense and T2 hyperintense multiloculated cystic lesion in the body of the fourth metacarpal bone, which was going with the diagnosis of aneurysmal bone cyst. So we did a true cut biopsy for the patient, but it was inconclusive, and hence we went for an open biopsy report, which showed the features suggestive of fibrous dysplasia. So subsequently, we planned the treatment as excision of mass with reconstruction of the fourth metacarpal using unicortical fibular graft. So now these are the pictures from the intraoperative period. So here we can see that the mass is being excised. And in the next picture, we can see that the mass has been excised. And this is the picture from the preparation time of preparation of the graft. And now here we can see the graft being placed at the site of the mass which have been excised. So now KY fixation was done, and this is the picture from the intrafluoroscopic image after the KY fixation. Then here is the immediate post-op X-ray. Post-operatively, the patient was put on a below elbow slab. This is the X-ray from the 6 weeks follow-up when the slab was removed and the movement was given to the patient. KY was removed at 2 months, and this is the picture of the X-ray from the 4.5 month follow-up. And finally, this is the X-ray from the 11th month follow-up. And this is the clinical picture of the patient from the 11th month follow-up. She regained her functions and there was no neurodeficit. And finally, coming on to the last follow-up of the patient, 15-month follow-up, where we can see that it is almost indistinguishable from the other. The fourth metacarpal is almost indistinguishable from the other metacarpals. And this is the clinical, showing the clinical picture where she can perform all her functions and she has regained all the functions. There is no sensory or motor deficits. Thank you to everyone. It was a short presentation. I could prepare only this in the short period of time. Thank you.
So that's Snejuti, very nice. It's always good to make a effort in the beginning, and for your residency level, I think this is good. You have done a very detailed compilation of the case as you saw it. Do we have any questions from any of the other people on the panel? Or can I ask her one? Can you stop sharing and switch on your video?
Yeah. Yes, ma'am, sure. Yes, ma'am.
Yeah. So would you have considered any differential diagnosis for expansile bony lesion when you encounter it in a young adult?
Ma'am, it could be TB dactylitis. It could be enchondroma.
Aneurysmal bone cyst, as you correctly pointed out,
Yes.
and suggestive of fibrous dysplasia. But what would be another sort of slightly worrisome diagnosis that one would see in a young adult? She's 13, you said, right?
Yes, yes, ma'am.
Suppose she was 20 years old, what would you have considered? Would you have thought of a giant cell tumor?
Yes, ma'am.
Yeah, it is a little rare. Agreed, it is a little rare, but that could have been one of the possibilities. And
Yes,
nowadays, the only tip I would give you is that, people prefer to do something like a FNAC or a J needle biopsy rather than a true cut. Because if this turns out to be a fibrous dysplasia, then
Yes, ma'am.
maybe just a curettage and supporting it with an intramedullary grafting would have done the trick. So either way, I think it's very good because what you've done is that you have used the fibula as an internal strut instead
Yes,
of
ma'am.
using a nail, because this region is very difficult for any other implant to be used. Yeah, and it's a very excellent result, but it's nice. Isi bahane, you will be stimulated to read up more about tumors, and hopefully we don't know what in future, but hopefully we'll have an oncosurgeon amongst us then, because that's another field in orthopedics which is little less explored in general, and especially by ladies. Yeah, so they should stimulate you to read up more and learn more. Neha, Ritwika, any questions, any of y'all? Sassy?
Can I ask one question?
Sure.
Yeah, Snejuti, first of all, congratulations. It was a very, very nice presentation, very fluent presentation. So my question
Thank you,
was,
ma'am.
did you send the en bloc resection again to a histopath, and was it consistent with the previous open cut biopsy? And
Yes,
was
ma'am.
there,
It was. Yes, ma'am.
and was
We
there
had sent
any graft side morbidity? you noticed?
No,
Was
ma'am.
there any
No.
delayed healing
And
in
that is why,
Was there any delayed
ma'am,
healing?
that is actually, no, ma'am. No, ma'am. And that is exactly why we chose the fibula as the potential site for taking up the graft, because other options were also there like metatarsal, but in that case there would have been other problems. So that is why we chose the fibular graft.
And what about operative site healing?
Ma'am, as we can see that the graft was taken up within a period of 11 months, which is what the common the different studies, especially like Chacha et al. There is one study, so the graft period time being about 12 months, so it was fairly taken up within 11 months, and she gained almost all her functions within 1 year down the line.
Okay. Again, very nice presentation and nice follow-up also. Congratulations again.
Thank you, ma'am. Thank you.
Good evening.
Yeah, Dr.
Can I
Ananda
make a
Kisharupal,
comment? Yes, can
please.
I make a comment? Actually, as being a co-surgeon with Dr. Congratulations, Dr. Snejuti. Actually, the one important question he has asked, that is the donor side morbidity. Yes, by fibula, there is a possibility of donor side morbidity, especially the flexor hallucis longus weakness. But actually, we used a specific minimal invasive technique with at least 2 centimeter incision above and below, and with making the periosteal slip intact. We remove all the periosteum with a special technique, so that there is a very little amount of soft tissue intervention will be there, and the fibula can be taken as it is. And that is the technique that will help us to prevent the donor side morbidity.
Yeah, Dr. Pal, lovely case. I think in a way, because she's a child, you would hardly really expect much of a donor site morbidity. And
Exactly.
except for leaving the lower fourth fibula station, I think we have a case similarly.
Yes,
Somebody is going to be
yes,
presenting
definitely. The
later.
lower 10 centimeters should not be touched about, and
Yeah.
that preservation of the periosteum slip, that will make a complete
they
regeneration of
regenerate.
the fibula, complete regeneration.
Yes, very
And
nice.
that is published in IGO, and
Correct.
it is I think it is 2010. There is a specific technique of taking the fibular graft.
Correct. So good, congratulations, Snejuti. And anyone else wants to ask any questions? Any of the other presenters also? Let's move on then, Ritwika. Sure. Someone is asking. Please go ahead.
Yes, another important point just to be discussed is the length of the fibula to be taken out. Actually, we considered the opposite side hand, and we took the measurement of the fourth metacarpal of the normal hand. That is one. And in that case, we preserved the articular sites, just sliver of bone in the proximal and the distal end, and we could preserve that. And then next, the whole amount of the rest amount of the bone, we replaced it. And actually, that trick actually helped us to prevent the preservation of the subchondral bone along with the articular surface, and that maintain the arch. That maintain the arch. If you see the post-operative radiograph and also the clinical, that will maintain the arch of the metacarpal heads. That is almost we preserved. That will help us to maintain the function.
Yes, that's right. Because on the pre-op X-ray, you could see that there was significant shortening of the metacarpal.
Yes,
so I think it's a beautiful result, and you all have done a very, very good job.
Exactly.
Yeah, and even the finger cascade was normal, so that's excellent. Let's go ahead, Ritwika.
Right. That was an excellent first case to begin with. Can I invite Dr. Kanchana to share for the next presentation?
Good evening, everyone present here. Special thanks to Woice India, IOA, and West Bengal Orthopaedic Association for giving us this opportunity to present our experience experiences and our cases. Today, I'll be presenting a case of post-traumatic acquired club foot in a basketball player, because it is a rather rare and a unique case, and the patient is currently still under follow-up. So without further ado, I'll just go into it. A 19-year-old male collegiate basketball player presented with a complaint of pain, swelling, and inability to move the right ankle following injury while playing basketball after 7 hours of injury. The patient had apparently landed on the lateral aspect of the right foot during the fall while taking a rebound while playing basketball. On clinical examination, the foot was grossly deformed and the foot was swollen. The foot was displaced medially in relationship to the leg, and it was locked in supination. The head of the talus was prominent, and it was felt dorsolaterally in the foot, and there was tenting of the overlying skin. There was no neurovascular deficit. The diagnosis of medial subtalar dislocation was made clinically, and it was confirmed radiographically. As we can see in these radiographs, that there is dislocation of the calcaneal joint and the talonavicular joint with medial displacement of the rest of the foot. Subtalar dislocation was defined by Zimmer and Johnson in 1989 as simultaneous disruption of both the talocalcaneal and the talonavicular joints without involvement of the calcaneocuboid and the tibiotalar joints, and without fracture neck of the talus. Broca in 1852 had described 3 types of subtalar dislocations based on the direction of dislocation of the midfoot or the forefoot. The first type was the medial subtalar dislocation, which is the most common type, followed by the lateral subtalar dislocation and the posterior dislocation. In 1856, Malgany and Berger had added the 4th type, that is the anterior subtalar dislocation. And the medial subtalar dislocation is also termed as acquired club foot. Medial subtalar dislocation or subtalar dislocations in toto is very rare, and it is seen in it constitutes about 1 to 2% of all dislocations, and it is commonly seen in young active males. And 10 to 40% of all subtalar dislocations present with open injuries. Most of the cases are related to high energy trauma, such as road traffic accidents and fall. And 19% of these subtalar dislocations are caused by sporting injuries or sprain injuries, which are relatively low energy traumas. During a basketball, when the athlete take rebound, most of the ankle injuries occur at that time only, because while landing from a rebound, the load that falls on each leg is more than or equal to 5 times the body weight, and it causes inversion stress if the athlete lands on the lateral aspect of the foot. Coming to the biomechanics of the subtalar dislocation, as we all know, in a plantar position, the calcaneum is pronated and abducted, resulting in a good contact between the joint surfaces of the talocalcaneal and the navicular complex. But when the foot is plantar flexed and supinated, the calcaneum becomes flexed, supinated, and abducted, which decreases the capacity of the acetabulum pedis to hold the head of the navicular, and there is less tension in the supporting ligaments. Also, in this position, in the supinated foot, the sustentaculum tali moves towards the posteromedial aspect of the posteromedial process of the talus. And when the load falls on in this situation, in this position, there is pressure across this joint, and since the sustentaculum tali has moved posteromedially, that near the medial process of the talus, that sustentaculum tali then acts as a fulcrum around which the talus subluxates when the load is applied, And with further force, it further results in dislocation of the talonavicular and the further results in this talocalcaneal joint dislocation. So associated with these injuries during this forced eversion and inversion, the calcaneonavicular ligament offers a strong resistance and it resists disruption. And the force that falls is dissipated through the weaker talonavicular and the talocalcaneal ligaments. So this allows medial or lateral displacement of the calcaneus, the navicular, and all the distal bones of the foot as a unit, resulting in either medial or lateral subtalar dislocation. So the mainstay of the treatment is a reduction of the dislocation under anesthesia. The technique for close reduction includes flexion of the knee to relieve the deforming force of the gastrocnemius. Traction is given through the heel with the foot plantar flex, and counter traction is applied at the thigh. This disengages the bones, and application of gentle pressure over the talonavicular joint and the talar head then re-engages the talus into the navicular with a clunk. The foot should then be dorsiflex to neutral position, and then it should be pronated. In our case, close reduction was done under spinal anesthesia with the above described technique of reduction. As shown in the first C-arm X-ray, as we can see that the dislocation has reduced. But on checking the stability of the reduction by ankle movements, we found that there was certain amount of subluxation that was taking place in the talonavicular and the talocalcaneal joint. Hence, it was decided that it is better to stabilize the reduction by using Kirshner's wires and the K wires, as you can see in the second and the third pictures were passed. Following this, we put a short leg splint with POP, and immobilization was started. So 10% of medial subtalar dislocations in such cases we may have difficulty in reducing because of certain factors like bony blocks due to impaction fracture of the talar head, due to interposition of peroneal tendons and extensor digitorum tendons. And in such cases, we require open reduction. In an article published in Journal of Foot and Ankle Surgery in 2007, Jerome et al. Had stated that CT scan should be done to confirm the reduction and should be obtained after reduction and splinting, so that small osteochondral fragments should not be missed. And it is very easy to miss these small osteochondral fractures in the initial radiographs because the foot is distorted. We did a CT scan of the foot and the ankle in our patient following close reduction and splinting with the POP, and the CT scan showed good reduction, and there were no osteochondral fractures, and there was no fracture of the talus. 10 to 40% of all subtalar dislocations present as open injuries, and they require immediate open reduction and fixation. Thorough debridement should be done at the time of reduction, and the wound then should be left open for delayed primary closure after 3 to 5 days. Now, the duration of immobilization in such cases is still controversial. The recommended period of optimum immobilization range from 3 weeks to 4 months. Zimmer and Johnson have recommended a minimum of 4 weeks of immobilization in older patients without associated fractures and without high activity demands. Perugia et al. Suggested 4 weeks of immobilization in a cast for patients without associated fractures, and Lee and Curtis stated that dislocations associated with fractures require immobilization for more than 6 weeks. So the recommendations varies from 3 to 4 months, and for our case, the follow-up plan was to immobilize the patient for 3 weeks and remove the K wires at the end of the 3rd week and continue immobilization for another 2 to 3 weeks with a short leg cast followed by vigorous physiotherapy and use of ankle range of movement brace, and followed by progressive weight bearing. So the complications that we can face in such injuries include stiffness of the ankle joint, especially restriction in movement in the subtalar joint due to fibrosis. And there can be post-traumatic degenerative arthritis. And in open subtalar dislocations, there can be infection and osteonecrosis of the talus. The prognosis of such injury usually depends mainly on the type of injury. Simple subtalar dislocations with early reduction lead to excellent outcomes, and poor prognosis is associated with lateral subtalar dislocations and dislocations with osseous and cartilaginous injuries, and open dislocations have the worst prognosis. So in conclusion, early diagnosis, reduction, and rehabilitation is necessary for good outcome. And the need of the hour is to adopt customized preventive measures suitable to the anatomy, biomechanics of the athlete's foot, and the demand of the athlete during the game, which will help us prevent such injuries that can compromise the athlete's career. Thank you.
Absolutely excellent case, Kanchana. This
Thank you,
should
ma'am.
become a case report in IGO.
Thank you, ma'am. Thank you, ma'am. Actually, I had presented this case with an intention that I would be able to discuss it with such an esteemed panel, because there is no specific or no standard protocol that has been defined for treatment of such an injury, and it is rather a rare injury. So, ma'am, as I would like to hear more from our panel. From the panel and all the esteemed faculties present.
So we have two budding sports and scopy specialists over here, Neha and Samundishwari. I would like to know their opinions on this injury pattern and how they would have treated in private, whether they would have done anything different or added any additional things to the protocol.
Yes. Samu, you want to start first? You can.
In addition to the CT evaluation, I would have done an MRI scan in addition to rule out smaller osteochondral defects, which can be picked up with MRI, and also the ligamentous injury pattern associated with it, so that I can plan my rehabilitation and the duration of immobilization accordingly.
Okay, ma'am. Thank you for the feedback, ma'am, because the patient is currently still under follow-up, and I will make sure that an MRI is done. Thank you.
Neha, any tips from you?
Kanchana, very nice presentation and very nice case actually, and very rare actually.
Ma'am.
Yeah. So first of all, along with CT, as Samu said, MRI would be a great choice because that will give us more idea about the ligaments. And while even telling the prognosis to the patient, because he's an athlete, so we need to assess the instability. So we need to see what ligaments are torn. So according to that, we can tell the prognosis to the patient. And if at all it's required, then if we assess the instability later, then we might tell him that he might need any reconstructive surgeries if the instability of the subtalar joint or ankle persists.
Thank you, ma'am.
So I have a question for all three of you. In case there would be an osteochondral fragment or something, would using a bioabsorbable suture anchor improve the result in any which way during the repair or the open reduction?
Yes, if at all we find osteochondral lesions, then according to the sizes, it varies. If it is a very small lesion, then it should be excised. But if it is fixable and it is acute lesion, then it should be fixed. Suture anchors are there, biopins are there, which can be used.
And can you tell us how soon the biopins get absorbed into the body? I mean, are they stable enough and strong enough to allow early weight bearing?
It's not about weight bearing. Yeah, they once the fracture is fixed, like within 3 months or so, the biopins will the osteochondral fracture will take over. Like the union will take over, and there won't be a role of biopin after that.
Okay. Okay. Anyone else? Any questions from any of the WBA office bearers or any of the other respected faculty here?
Ma'am, I would like to ask a question.
Sure.
Excellent case, Dr. Kanchana. Is
Thank
there
you,
any
Ritwika.
role of a spanning X-fix in such cases?
Well, there is, because especially in open cases, we have to fix it, and it is not advisable for us to put like implants inside when there is an open injury. So in those cases, to maintain the stability of the joint, we need to put spanning X-fix, yes.
But not in routine cases.
No, because as far as I have read up, usually they say uncomplicated cases don't require any fixation because it is usually stable after closed reduction and immobilization.
And I also wanted to ask one more thing, that suppose this were a chronic injury, then what would have been your strategy for treating the same? And suppose if it's I mean, in our country, assuming that it is something neglected, say a child falls from a tree and rarely ends up with something like that. Is there a chance that you would need to do something like a triple arthrodesis or something if it was a 12,
yes,
13?
definitely, because we would rather go for a painless joint, which is even though we won't allow mobility, but at least it will be painless. So I'll definitely have considered triple arthrodesis.
If it's a chronic or neglected.
Yes, yes.
So it's very interesting to see what you've shown, especially with respect to the subtalar biomechanics. And
Thank you,
when you
ma'am.
said acquired clubfoot, I was almost hoping that this would be treading into my territory and seeing a pediatric case there. But just to draw your attention to, since you're interested in subtalar joints, maybe you could read up the Farabuff's concept of movements at the subtalar joint, which are rolling, yawing, and pitching, just exactly the way a boat moves. And hopefully, if in an athlete, if you can restore all three of these movements, that would give him much more agility on the field and return to his previous sporting career. Fantastic. I think this is really something great. And I'll take this opportunity at this juncture to remind all of you that the Waves membership is free up to APOA Waves membership is free up to the 31st of March this year. So I'd really be happy if all of you can participate in that short essay contest. And maybe even, writing up something like this for the APOA Waves Connect magazine. It'll be a good idea to show Asia Pacific that there is such a lot of talent and, rare cases also which we can report from India. So I would strongly encourage that.
Yes, ma'am. Thank you, ma'am.
Great, Ritwika. I think let's move on.
All right, ma'am. Ma'am, I will share the screen. Is it visible, ma'am?
Yes. Yes.
Okay. Thank you. I would like to present a case on bilateral asymmetric hip dislocation. I'm Dr. Ritwika Nandi, a senior resident from West Bengal. So the case in question, it was a 34-year-old male. He was sitting in the passenger seat of a truck, and there was a head-on collision with another truck. And he presented to us around 24 hours since the injury. He had received some kind of basic care somewhere. And he had presented to us with a very typical position of attitude of both his hips. So his right hip was in the flexion, adduction, internal rotation position, whereas his left hip was in flexed and abducted and external rotated to an extent. So we got a radiograph which confirmed our suspicion that there was a bilateral hip dislocation. There was one side posterior and the other side was anteriorly dislocated. After the initial assessment, we immediately posted the person for closed reduction under general anesthesia. And this is a post-reduction radiograph which revealed a posterior wall fragment. CT scan showed that it was a prominent fragment because we had put skeletal traction for both the sides after the reduction. The side which was posteriorly dislocated was kind of unstable when we were applying telescopy in flex position. The hip was found to be subluxated. So we planned surgery for the patient. Hip dislocations, simultaneously bilateral hip dislocations, asymmetric ones, are very rare. They consist of 0.01 to 0.02% of all cases. And it is important to rule out other injuries because more often than not, it is associated with acetabular and femoral head injuries. Early reduction within the first 6 hours is the mainstay of management to prevent the main complication, which is avascular necrosis of the femoral head. However, in this case, as the patient had already presented late, he was already counseled from the time he had presented to us that there is a high risk that in the future you might require something for the AVN. A case report here, this analysis, 104 cases were analyzed, and the most common reason for this kind of a case was found to be RTA, followed with fall from height. 53% was associated with an acetabulum fracture, and 18% was associated with a proximal femur fracture. The number of cases definitely been on the rise, since the incidence of trauma has also been increasing in the last decade or so. The most cases, 91%, was just managed with closed reduction. However, in our cases, we plan to go ahead with fixation of the fracture via KL approach. We used a standard approach. The fragments were reduced and we used 2 spring plates to stabilize them. This was a post-operative radiograph immediately. The patient was allowed weight bearing after 4 to 6 weeks because anyway the other hip was immobilized for the time being, but passive range of motion of the hip was started after 2 weeks. This is a final comparison 3 years from the injury. Currently, the patient is definitely showing features of avascular necrosis on radiograph. However, when we question him and he has returned to work and he has no other complaints as it comes to his daily activities. So we are still evaluating him and we will see what happens in the future. This is current function now. Thank you.
Excellent result. What does he work as, Ritwika?
Ma'am, he was a truck driver, but because of the accident, he has some phobias associated. So he's now opened a shop, and he's a shop business owner now.
So what would you explain to him in terms of what to expect in prognosis about osteoarthritis and all in future?
Yes, ma'am. From the beginning only, the first time he presented to us, we explained to him that there's a high probability that you're going to have avascular necrosis of the head. There's going to be something wrong with your hip. There might be pain. There might be restriction of movement. You might have difficulty when it comes to squatting or sitting cross-legged, and you might require a further surgery if we deem at some point. So it is important for him to be in constant follow-up. And as and when the situation arises, we will guide you through the best procedure possible.
So any recommendations on at what age normally they get painful in such cases, and how soon do they need a hip replacement?
Ma'am, it's varied because there's no proper recommendation, but within 6 hours, if it's done, then the incidence was very less, around 20%. Whereas that, if it is done more than 6 hours later, the total incidence has come up to 70% perhaps, that the future need of a future surgery. So the time, ma'am, I have to look up. I'm not yet sure about the exact time from the time of injury.
Anyone else? Any comments? Any?
What is the last follow-up, Dr. Ritwika? It was a good case.
Currently, he's 3 years after the surgery. And this was his function right now. He doesn't have any pain, but definitely on radiology, we can see some changes. We've advised him to get an MRI, but he's yet to think about it. And he's like, because I don't have any complaint, he's delaying the further procedures.
I'd like to take an MRI for this patient. And then I would like to intervene early so that I can prolong the need for replacement in a later years. There are a lot of advances in hip arthroscopy we do, arthroscopic cord decompression we do, and then if there is a labral tear or any other intra-articular pathologies, we can subsequently advise the same setting.
Right, ma'am.
How about starting some alendronate or, at least putting him in some medication?
I might have to look up if we can start him on it at this stage.
Yeah, so there'll be, I think, some interesting publications by Dr. Sanjay Agarwala and I forget the name of the first author. Someone from Bombay had, I think, published a fairly long series on the role of preventive alendronate.
Right, ma'am. But
Siddharth
as
Shah,
his
I think.
arthritis
Yeah.
is already started, I do not think it is going to be of much use.
Yeah, okay. But I mean, maybe if there's a specific role, then maybe you could look into that.
Right, ma'am. Right.
Yeah. Neha had a question, I think.
Hi, Ritwika. Very nice presentation. Basically, very nice results. I just wanted to know, have you encountered heterotrophic ossifications in acetabular fractures? And do you always counsel the patient about it? Or do you take the consent like we take for AVN? Do you take for heterotrophic ossifications as well?
Yes, ma'am. We had taken for this patient specifically because we had opened the patient with KL approach. There was definitely a chance of it happening, and we had also explained to him that there's more chance of it being asymptomatic than causing a problem. And if it would have caused a problem, we would have gone ahead with some management. But it wasn't one of the main factors. We had focused on the risk of AVN and definite chance of osteoarthritis for this patient particularly.
Right. Okay.
Thank you, ma'am.
Thank you.
Lovely. I think let's go ahead with the fourth case.
Right, ma'am. Can I invite Dr. Surabhi to share her screen?
Good evening, everyone. Is my screen visible?
Yes, you can play presentation, share presentation.
Go ahead.
Yes, ma'am. Good evening. I shall be present. I'm Dr. Surabhi. I'm a junior resident in AIMS Rishikesh. I shall be presenting a case where we had an open both bone leg fracture with a distal fibular bone loss, which was addressed with a unique sliding osteotomy. So we had a patient, 30-year-old male, who had a wound, pain, and inability to bear weight over the left lower limb. He was in a road traffic accident on the 6th of January 2022. And he came to us with a bleeding wound and an open fracture. He had no other symptom. He had no other symptoms like there was no LOC, there was no seizures or ENT bleed. We took radiographs. This was which showed that we had a both bone leg fracture with a fibular bone loss. Diagnosing it as open grade 3B both bone leg fracture left side. We went ahead with wound debridement and external fixator application on 6th of January 2022. This was the wound condition post debridement and post application of X-rays. STSG was performed on a patient about a month later. And this was the local skin conditions prior to the definitive surgery we had planned, which was intermedullary nailing for the tibia, which were about 2 months post injury. We went ahead with CRIF, closed reduction internal fixation with intermedullary nail, and open reduction internal fixation of fibula. We made a cut about 6 to 7 centimeters above where we had the bone loss. To take about a 6 centimeter proximal fragment of fibula, we slid it down and we slid it down and we plated it to form that lateral support of fibula that we need so that we can start weight bearing for the patient as early as possible, and it would not go into valgus or valves. These were the wound statuses post-operatively and after 2 weeks. At 4 weeks follow-up, we can see that the alignment is very good, and there are signs of union. This is at 8 weeks follow-up, and this is at 3 months follow-up, where we can see that since the sheath was placed, since the periosteum sheath was intact, there is calcification, there is bone formation in that sheath, and the fibula is forming again. This is at 8 months follow-up, which is the current follow-up. Clinically, the patient is better. We can see that the ankle movements are adequate, as well as the knee ROM is adequate. This is his gait now. Thank you.
Questions, Neha? Very nice result.
Yes. Yeah, very nice results actually. So my question was, did you slit that fibula in one go, keeping the periosteum intact, or was it gradual? And the distal part of fibula, was it fixed to the tibia?
Ma'am, the distal, only the malleolus was intact in the distal part of tibia, with the distal part of tibia. The rest of the fibula was not. So we had about 7 to 8 centimeters of bone gap, bone loss from that site. So we needed a 10 centimeter strut on the left side. We thought we had planned either a strut graft from the opposite side, but that would also cause donor site morbidity on the opposite side. So intra-op, we were in a dilemma. We thought this could be a very good option, that we slide the same fibula down, a portion of the same fibula down, and create that lateral strut. And we did it at one go, ma'am. It wasn't gradual.
Okay, good.
So any other mode of fixation would you have used other than a plate? Maybe would you have considered a ring fixator to stabilize it better, or an intramedullary wire or something?
LRS?
Yes, ma'am. But since the patient was already on an external fixator for 2 months, and we wanted to give him early weight bearing as soon as possible. So we wanted to go with the nailing, and intra-op, we took this decision once we performed that fibular osteotomy, slid it down and plated it. We found that there was enough stability. So we went ahead with it.
That was very nice. Could you have added additionally another bone graft? Because we do see, I mean, it's nice to see that in an adult also the fibula has reformed, but it's a little flimsy and perhaps not great enough for weight bearing in the middle third. Of course, we can do without it because the tibia is united beautifully. But would you have considered additionally maybe a cortical bone graft from iliac crest, or maybe a cadaveric graft, allograft, to just bridge the gap? Since you were plating it, you could have used a long plate and done that.
Yes, ma'am. We'll keep that in mind.
No, but that is just an additional thing. I mean, suppose it's a very athletic patient or something like that, but literature has very clearly shown, like one of the previous co-surgeons told us clearly, that you cannot do without the lower fourth of the fibula, but you can easily do without the middle third of the fibula. So,
yes, ma'am.
What was your weight bearing protocol for the patient, same patient?
We started weight bearing, ma'am, toe touch weight bearing from POD2, and then we increased it as tolerated, and by 1.5 months, the patient was walking bipedal with a full weight bearing.
Okay.
How was the function of the foot? Like, for example, you had multiple surgeries, so anteriorly there would have been a scar, big scar, and laterally you have exposed so long to pull down the fibula. So, did you have any like particular dysfunction of the ankle?
Ma'am, laterally we only made a very small incision, about a 2 centimeter incision from the site of osteotomy, and we pushed the fibula down along the periosteal sheath. So there wasn't much of a wound on the lateral side iatrogenically, but the wound that was already present due to it being an open fracture, that had healed quite well with the split thickness skin grafting. So the ankle movements were good, ma'am. We had started him on ankle ROM exercises from very early stage. So we achieved a plantigrade foot without any deformity. Yeah.
That's a great case.
Yeah. I think all four have been very, very nice, very varied presentations. And Dr. P.K. Mullah Firoz would have been extremely proud of each of you girls. So I think we are really living her dream and bringing it, taking it further. Is any of our WBOA office bearers here, and would they like to say something? Why don't every one of us switch on our cameras and hope somebody's been taking screenshots? I, of course, can't figure in that camera because my new laptop won't allow it, but
Yes,
never
ma'am.
mind.
Modi sir
I
is
think
here.
still I should go ahead with it.
Yeah, I'm Dr. Shomudi. I'm the scientific coordinator of WBA. Thank you, Rujuta ma'am, Somu ma'am, Neha ma'am, and all the speakers for nice presentation. It's a great day for WBA because we are starting these things first time, and we'll continue it again and again. We'll perform many such meetings in future, and we'll need all your help to promote these juniors.
Sure. So I would sincerely request each one of you all to, sit with them before the webinar or any of the sessions and help them edit their presentations, add some more elements, have some sort of a rehearsal. Of course, they were all fantastic, confident speakers. I would never have imagined that they were first-time speakers today. So I think that was one very, very creditable thing. But just to make sure that, they get it, they nail it and make it so crisp that we all would be, we are proud of them, but we can be even more proud of them.
Thank you, ma'am. Yes.
And please do get all the 7 sisters of Nerosa along for the July meeting. I think it would be very nice to connect with all of them. Kanchana?
Yes, of course. We are planning to have it in our East Zone conference also. This year, our East Zone conference is in Guwahati. So we can have a East Zone session also.
Because we have a Telegram group, but we realized suddenly during IOCON that there were some who were not really on the technical side so much. And then there was the Dr. Sarkar, who we would have been, and she's pretty senior. We would have loved her to be part of this. So I'm sure there are many more women orthopods which we'll discover if the East Zone reaches out to the Nerosa, and with Kanchana's help, I think we can bring all of them together. Yeah, Valencia is already there doing a great job. But yeah, true. So fantastic.
Thank you, ma'am. Thank you, thank you, everybody. Thank you so for giving us this opportunity today.
And thanks to OrthoTV. And once again, thank you, Ritwika, Rajeev, IO President Sir, and all the office bearers of WBOA. From the land of Maitri and Gargi, I think this is very, very scholarly women which you all have brought out today. Thank you so much.
Thank you, ma'am.
Bye-bye.
Everyone.
Bye.
Bye.
Thank you, ma'am.